Okay, welcome back, everybody. Okay, so just to get this session started, you all know who I am, Michael Rynne from the CLL Advocates Network Steering Committee, and it's my honour to actually chair this. The current treatment landscape of CLL. Many questions. Let's hope some of it will be answered, but it's always very confusing with all the advent of all the new therapies. It's my honour to introduce Professor Florence Cymbalista. From Paris, France, who's Professor of Haematology and was in the Haematology department at, I hope I can pronounce this right, the Hospital Avicenna in France. She's been involved in CLL for 30 years, both as a clinician and clinical and basic research. A member of the French cooperative group on CLL, which is called PHILO, and a long-standing member of the ERIC since its foundation. So it's my honour now, Professor Cymbalista, to welcome you now to the...
Thank you. Well, thank you very much for the invitation. And as I think that probably most of you are not professionals in medicine, I decided that I will try to explain the different treatments and the way they work and why we are using them and how we want to use them. So just, I don't have the slides there.
TV on the front is not on.
So just a quick reminder of how cells work. I mean, cells have survival mechanism, and when the cell is normal, there is a perfect balance between cell survival and cell death. Cell death is triggered by what we call apoptotic protein that are allowed to activate the cell death. In CLL, the balance is not good, because what we have is that we have the signal, we have the BCR, the B cell receptor signaling that is high, and that leads the cells to go into the lymph node, and in the lymph node they proliferate. So that gives enlarged lymph nodes and an increased cell survival and proliferation. So the balance is tipped. And on the other side, we also have a decreased cell death because there is an overexpression of a protein called BCL2, and this protein sequesters the pro-apoptotic protein and prevent them for inducing cell death. So with these two mechanisms, we have been trying to target for many years these mechanisms, and the first that came out were the BTK inhibitors. The BTK inhibitors, BTK is a protein which is in downstream of the B-cell receptor, and when you target it, you just cancel the signaling capacity of the receptor. So the cells that have been directed to the lymph node, they leave the lymph node, they egress, and there is also no proliferation because the proliferation takes place in lymph nodes and not in the blood. And so you have a progressive clearance of the cells because there is a rapid lymph node regression, and as you might know, there's initial lymphocytosis and then it decreases. So it has been really a breakthrough in CLL treatment, and it's also known for its efficacy, including in patients with alteration of TP53. And there is a prolonged PFS now with the trials.
So remind us what PFS means.
Oh, okay. There is a prolonged progression-free survival as compared with chemoimmunotherapy, and notably in unfavorable disease, which are the unmutated IgHV cases. So the problem is that it's a treatment that patients had to take every day until reprogression of the disease. So they are certainly a big step forward in CLL treatment. But, you know, as all treatment, they have side effects. They have cardiac side effects, bleeding, hypertension, cutaneous, and some others. The patients with certain comorbidities cannot receive this treatment. For example, cardiac failure and high bleeding risk. And there is an increased risk of complication for the patients who have an uncontrolled hypertension, arrhythmias, or with drug interaction. So, as I said before, it's a continuous treatment until progression, so there is a risk of the development of resistant mutation. So, this is for ibrutinib, which was the first BTK inhibitor, but now we have covalent second generation BTKs that are more selective. So, because some of these adverse events are targeted by effects on other proteins. And so they are as effective as ibrutinib, like zanubrutinib or acalabrutinib. Well, these are barbaric names, I'm sorry. But, they are as effective, but they are even more effective because there are less discontinuation because of less side effects. They reduce the cardiac risk, but the risk of resistance remains the same. So there is a third generation BTKI that doesn't work at the same spot, which can be used when there is a resistant mutation. And there is also a new class which are called BTK degraders, but these are still in early phase for the frontline treatment. So there is a challenger to this treatment that came a little bit later on, especially in some countries. It's venetoclax. Venetoclax is what we call a BCL2 inhibitor, because what happened is that venetoclax targets the BCL2 and allows the release of the free apoptotic protein, which are able then to activate cell death. So the balance is reestablished. There is an increased efficacy of venetoclax if you add antibodies such as anti-CD20, rituximab, and even more obinutuzumab.
So can you remind us what anti-CD20 means? And just, I know that you covered this before, but apoptosis,
yeah.
Like cell suicide, just you could go over those terms a little bit. Yeah.
Okay, so apoptosis is cell death by a certain mechanism, and anti-CD20 is an antibody that targets a protein which is present on B cells, which is called CD20. So it kills the cell through that interaction. In frontline, venetoclax obinutuzumab is used for a year. The association is used for a year. And, but there are adverse events, as with all treatment. There is what we call tumor lysis syndrome. It's so efficient that when it kills the cell all at the same time, you might get renal insufficiency and renal failure. So, but now as hematologists, we are used to that mechanism because it happens in other leukemias. And so it's not so much of a problem now because we know how to deal with it. It induces also neutropenias, decrease of the white blood cells, but this is not too much associated with a lot of infections. But of course, it's to use with a lot of caution with patients who have problems with their kidneys. So this treatment is very efficient. It has a good tolerance, and it has been shown the tolerance is good also in elderly patients. And it's also a treatment just for a year, and then the patient is free of treatment until the relapse. So, of course, there is now the question, well, we are richer than we were, and so how do we choose between venetoclax, anti-CD20, and BTK inhibitor for the first treatment of the patient? So I think that even if we know a lot of things in biology, the major issues for decision making are still the comorbidities, because some patients cannot receive BTK inhibitor, the co-medication, because they can interact with these drugs, and of course the patient preferences, because it's not the same to have a pill every day, but a continuous treatment, or to go to the hospital every month for 6 months, and then have a treatment for a year, but a discontinuation. So the clinical presentation is also something that we take into account. If the CLL is very progressive, there is a short doubling time of the CLL, meaning that it's very proliferative. And there is no very bulky disease. It means that the lymph nodes are not too enlarged. With some biology, I will not get into it, but so we rather choose a time-limited treatment with venetoclax. But if the disease is very bulky, we need the cells to leave the lymph node, and so we'd rather favor the inhibitor of BTK. And also, if there are some very unfavorable genetic alterations. So I'm going to go very quickly through that slide. There were studies in what we call the real world outside of trials. And all these studies pointed to the fact that the real-world study with venetoclax were encouraging, and they are supporting the goal of developing combination with that drug for elderly adults. And because initially with BTKI, there was a difference between the patients who were into trials and the patients in the real life, because it was less well tolerated in real life. So I just want to illustrate with 3 clinical cases. Mrs. O, she is retired, she is fit, she has no comorbidities, she has no high-risk factors, and so she has a progressive CLL stage B, though she needs to be treated. Mr. L is elderly, he is unfit, he has a lot of comorbidities, and he has thrombocytopenia. And Mr. V, he's 55 years old, he's an active businessman, and he has a rapidly progressing disease. So when you look at these 3 patients, you think, well, they are all eligible for venetoclax or obinutuzumab for treatment for a year. But Mrs. O, her husband has lung cancer, she lives in the countryside, she's far from the hospital, and she doesn't want to go to the hospital for anti-CD20 every month. So maybe we're going to give her a BTKI. Mr. L has seen his his general practitioner, and he has been recently diagnosed with dementia. He lives alone, and so we do need a geriatric assessment to make a decision and know how we are going to treat him. And considering Mr. V, he has very high-risk feature when you do the biological background. He has unmutated IGHV, a TP53 mutated complex karyotype. All these biological features mean that we would like to go a little bit stronger than just VO. So you see that the decision-making really has to take care of what the patient is in his life. So to go to Mr. V and the treatment that we may propose, I mean, there is an association. We have seen that the BTKI is targeting the proliferation side, and the venetoclax is targeting the cell death. So there is a strong biological rationale to associate both, because the BTK inhibitor can have the cell egress the lymph node, and then the venetoclax can come and kill the cells. It's a combination of our most efficient targeted drugs. The toxicities are not overlapping. It's a time-limited treatment. I won't go into how long, because this is not really decided yet. And it should reduce, and it does reduce, the emergence of resistance. But of course, it's also an addition of toxicities. So in non-high-risk patients, there are no yet convincing data that it might do better than venetoclax or obinutuzumab, because we don't have in a trial the direct comparison of both. In frail patients, it is important to consider that there are cumulative toxicities, and data from trials, all the trials have been done with the first generation BTKI, which is ibrutinib, and the data from trials with second generation that are less toxic are coming, and they are warranted. And in patients with rapidly progressing disease with enlarged lymph nodes, it's an interesting option for rapid efficacy. And in high risk, you can also, to that mixture, add an anti-CD20, and this is currently being tested. So it's true that the 5-year overall survival has increased a lot in these last years, from 65 in 75 to 87 in 2021. Of course, this is the use of the targeted agents, but not only. It's also because there was a great improvement of preventive and curative measures against infections, because you all know that infection is really something very scary in CLL. So vaccination, immunoglobulin substitution, antibiotics. There is a better knowledge also in this last year of the off-target effects of the therapies, because in the beginning we were a bit, it was difficult for us to understand why, for example, with BTKI we had arrhythmias. And so that fostered the collaboration with other medical specialists, and now we are currently working with cardiologists and nephrologists. Outpatient care also, we are trying to raise a better awareness of the general practitioners. And of course, we need for that also, we need very much the help of active patient associations. So how now from there we can optimize outcomes? Well, CLL care now is mostly outside of the hospital. So of course, it's extremely important, even if it was already before, to consider patient way of life, bring enough information to general practitioners. And I think that it's extremely helpful to be able to hire nurse practitioners that can call the patients and follow up the patient outside of the hospital. We need clinical trials, but we need randomized clinical trials that ask the right question, meaning through academic. We need longer follow-ups after the trials or after relapse, after one first treatment. And whatever the frontline treatment, we need to think about the sequence, because the CLL patient doesn't receive only one treatment. And we also need to collect valid information from the non-eligible patients. And we have a very larger knowledge of biology than we are currently using. So we need to integrate the biological knowledge into more personalized therapy, expand the current recommended testing to all patients everywhere, and the genetics, immunological background, epigenetics, and so on. Thank you for your attention.